So, to all those who are watching, welcome. Our session today will be on exploring lived experiences of LGBTQ people utilizing healthcare services in rural Manitoba. And our presenter today is Nadine Henriquez. Nadine is a registered nurse, assistant professor in the Department of Nursing at Brandon University within the Faculty of Health Studies in the areas of older adult health and palliative care. She obtained an undergraduate degree from the University of Manitoba and a master's degree from Athabasca University. She has 21 years of professional experience in a variety of settings, including nursing management, case management, which includes community, hospital, there's home and community care, palliative care, and surgical settings across 3 provinces and 5 different regions. Her research interests focus on the healthcare experiences and needs of LGBTQ persons in rural settings, nursing management, rural stressors, and nursing experiences participating in medically assisted death. She is interested in the education of nurses and other healthcare providers on LGBTQ health and improving inclusiveness in care settings and care at end of life. She is currently an assistant professor in the Faculty of Health Studies Department for Nursing and also serves as a director on the board of directors for Palliative Manitoba and a volunteer education ambassador for the SAGE National Resource Center on LGBT Aging. I am now going to pass it on to Nadine, and you can take it away whenever you're ready.
Okay, great. Good morning. Thank you, anybody who's joining here this morning. I'm really thrilled to be able to present this data from a study that I've conducted over the last couple of years with you this morning. So just to start off with, my name is Nadine Henriquez. I am a registered nurse, and I have been with the Faculty of Health Studies now for 5 years. My pronouns are she and her, just for starters. So I guess start from the beginning here. Whoops. So the study is entitled Utilizing Healthcare Services, Exploring the Lived Experience of LGBTQ people. And so we've used this acronym in the study, not for the sake of exclusion of any other identities, but for the sake of simplicity and related to much of the literature and the acronyms that we found most frequently used at this point in time. I do recognize that other acronyms are used by a variety of organizations. So again, this was for the sake of simplicity during this study at this point in time. And so you'll notice the quote underneath saying you don't actually exist. And this kind of captures the nature of a lot of the experiences of individuals that we interviewed during this project, and the lack of recognition of identities and individuals as people. So myself as the principal investigator on this study, I also have my colleague, Dr. Nora Ahmad, assisting with this research. Okay, so just a little bit of background on the study. In our research and review of the literature, we found significant evidence with regards to negative health impacts that individuals had related to their experiences within the healthcare system. Insensitive, negative, discriminatory attitudes towards LGBTQ people within healthcare continues to negatively impact access to health services and the overall health and well-being of this population. Providing health care to LGBTQ persons requires healthcare providers to be sensitive to the historical stigmatization this population has experienced, knowledge about barriers to care that are being faced by individuals, risk factors, and health conditions, as well as awareness of cultural aspects in all interactions. Overall, the research has indicated that there's a significant need to improve the cultural competence in the healthcare system in order to provide more sensitive and competent care and better meet the needs of the LGBTQ community overall. So our objectives in this study, overall, the goal was to examine the lived experiences of LGBTQ people utilizing healthcare services in rural Manitoba. So the study sought to identify any gaps in the healthcare services, areas of healthcare provision lacking in cultural competency and inclusiveness, as well as barriers to accessing healthcare. So this study is hopefully going to ultimately contribute to a better understanding of the unique healthcare experiences and needs of LGBTQ persons in rural Manitoba. And although we sought individuals who were accessing healthcare in rural settings, given the nature of how healthcare is delivered in Manitoba and across Canada, individuals in rural areas often experience lack of services of certain types, any specialized care, etc., and sometimes even healthcare in general, just even to your basic physician's office, etc., might not be available in a very small community. So sometimes individuals were having to travel to more urban centers outside of the community that they lived in. So we were considering individuals who had accessed healthcare just in general in this province, as many found that they had to travel for healthcare. Methodology. So our study was guided by the phenomenological humanetic perspectives to try and help us to understand and attach meaning to lived experiences. And so this study, participants were therefore asked to describe all their experiences accessing a variety of healthcare organizations throughout Manitoba, as I had identified, both rural and urban settings. So it ranged from hospitals, clinics, mental health services, as well as urgent care settings. Participants were asked about factors that encouraged or discouraged access to health services. We were asked for their thoughts and experiences regarding their ability to disclose their sexual or gender identity to their healthcare providers. We asked them further about concerns and fears regarding the reactions of healthcare providers towards their sexual or gender identity. We also asked them things about the settings themselves, including the presence or absence of LGBTQ equality signs. We asked about word choices on health intake forms that were encountered, and just overall impressions of the cultural competency levels, or the levels of knowledge of healthcare providers regarding the LGBTQ community. And so we also asked overall, suggestions for changes and improvements that they'd like to see in healthcare settings as well. So we'll take a look at some of those components. So with regards to recruitment, we targeted individuals aged 16 and above who self-identified as being gay, lesbian, bisexual, transgender, queer questioning, or other. So we left it quite broad in that whatever you identify, any non-heterosexual or non-binary gender identity, or both, however individuals identified. And so anybody having access healthcare services within the province would then be considered to be eligible. So due to the nature of the study, the unique characteristics of the target population, purposive and snowball sampling were used. Participants were sought through the Sexuality Education Resource Center here in Brandon, as well as the Rainbow Resource Center in Manitoba, as well as their social networks, and through their social media as well. So a total of 12 participants were interviewed, and data saturation was achieved at this point in time. Our preliminary findings. So we broke our findings down into several themes that appeared throughout the interviews. So we broke these down into stigma and discrimination, judgment and assumption, gender identities, lack of knowledge, and limited access. Now, there may seem to be some similarities between some of the categories, and so there may be further distillation down as we continue to work with our data. However, these are our preliminary findings at this point in time. So our first category, stigma and discrimination. So this is further broken down into a number of different sub-themes. So in things that emerged included fear of disclosure, concerns around safety, emotional exhaustion, dehumanizing experiences, and avoiding of care and services. So fear of disclosure. So individuals spoke about how they are never certain whether or not they should reveal their identities to their healthcare providers in these settings. One individual stated, it's like a risk every time, you know, every time you go to a doctor, it feels like a risk, whether it's a different doctor or a nurse or you don't know. So just that concern that with every new face, that there's going to be an unknown reaction and that it's going to be potentially a negative reaction or an unsafe setting. Some individuals questioned overall what kind of reception they were going to get, because they're going there for medical help and they're wondering what kind of questioning they're going to have to face when they try to reveal their identity to their healthcare provider. And just a general sense that there is not going to be any welcoming in that setting as well. So if they go into a setting and see nothing that indicates this is going to be a safe setting, they're not certain whether or not they can reveal any part of their identity. Some individuals also described feeling uncertain, given rural areas seem to have a little bit changed attitudes in the sense that it's a less safe setting, that there's some closed-mindedness, as some individuals described in some of these settings, and that individuals feel less safe as opposed to going to more urban centers. The next sub-theme, emotional exhaustion. So participants described feeling intense anxiety related to disclosing their identity in healthcare settings, feeling that this disclosure would make them vulnerable to mistreatment or even denial of care in the case of some individuals' experiences. So several individuals described how there's really this incredible vulnerability in explaining, defending, and re-outing one's self, and whether or not that space feels safe. So the uncertainty of entering any public space where you're often sick and unwell when you're seeking health care and already feeling quite vulnerable and needing help, but being further burdened by the concern as to whether or not it's a safe setting where you can disclose your identity, be validated in your identity, and receive comprehensive care that really recognizes your personhood, or if it's going to be one where you're ignored, mistreated, or misunderstood. It was described as a really frightening experience when you were feeling sick and vulnerable, and many individuals described not feeling like they had the energy to disclose so many times in these kind of settings because they were so unwell. And as you can see from the quotes here on the screen, this was a repeat experience for all of the participants. One individual described, I've just had so many queer and transphobic experiences in medical care that I sort of pick and choose, or have to historically pick and choose my disclosure based on necessity and emotional boundaries. So deciding whether or not they felt strong enough in that particular setting, in that particular day, to disclose who they were to their healthcare providers. And it was described also by all participants as requiring more energy than simply having your healthcare needs attended to, that it often took the shape of defending and advocating for oneself. And as several participants described, you were not often well enough to be able to do that on any given day. So this kind of brings us into our next section. And as you can see, there's some significant overlap between the sections, but we really tried to distill it down into just kind of the most important points within these different categories. So judgments and assumptions. We broke this down further into some subcategories, including making assumptions about identities, judgments based on stereotypes, biological gender markers, or personal beliefs, and asking intrusive questions based on curiosity versus need to know. So participants described a variety of experiences, ranging from providers making assumptions about the nature of their relationships with their partner to assumptions on gender based on physical appearances. And often these assumptions were based on stereotypes and preconceptions. And so overall, we found that the nature of the assumptions, according to the participants, are based on the failure of the healthcare provider to ask appropriate questions, or asking questions in a way that really prevented the individual from feeling safe or able to disclose. For example, a healthcare provider asking a female patient who appears to be female during an assessment if they have a husband or if they have intercourse, or questions around pregnancy, and making assumptions that this individual identifies as heterosexual. So every single participant described experiences where the healthcare providers made these type of assumptions. And so, and also the opposite end of the spectrum, assumptions or making or asking intrusive questions based not on that necessity, but out of curiosity. One participant described being asked about sexual reassignment surgery during an assessment for a chest infection, where it had really no relevance to the particular care in that particular scenario. So our first section in this category, dehumanizing experiences, so lack of trusting or inclusive care. So this is those assumptions based on experiences, based on societal gender stereotypes that individuals described. And I have a lot of quotes on the screen here right now, but I really had a hard time distilling it down because I felt they were all so important to share. And one individual described it's just kind of made it like where I wasn't worthy of support or help because they kind of just pushed me out because of their judgments, I guess. Another individual saying, I find it very discouraging to access almost any health services, to be totally honest. Another individual described a situation, the last quote on the screen, that they've had a counselor trying to convert them, like to Christianity or whatever, and like saying that you can't be checked and that kind of thing. And so actually being denied service and stating they didn't feel like it was a very good standard of care. And the first quote on the screen, which I think is really important to highlight, individual stating, like it's such an intense experience. Homophobia is such an intense in your own body, and like, so I think shame is the answer, right? Like I feel a lot of shame about it, and I wish I could talk to the physician without feeling that shame. It's a really powerful statement there. So our next category that we looked at was gender identities. So this is further broken down into stigmatization, medicalization, which is essentially that process of reducing persons into biomedical terms, using language of biology, and it really serves to facilitate detachment of the clinician from the patient. So really focusing on the disease or issue itself and really not considering the person behind the disease or illness that they're being treated for. The other issue that we identified was pathologization. So this is the assumption that being LGBTQ represents a defect. So according to the current criteria in the Diagnostics and Statistics Manual, an individual must be diagnosed as dysphoric and receive mental health diagnoses, be assessed by psychiatry in order to qualify for any kind of physical transitioning for an individual who is identifying as transgender. And the fact that not all transgender persons feel dysphoric in their bodies, not all are distressed by their physical body, not all want to transition physically, or they may only want to transition partially. There's a lot of assumptions that individuals feel dysphoric and that everyone wants to transition in the same way, contributes to that pathologization. So there's a lot of reinforcement of old biases that sexual orientation, gender identities are the problem versus heteronormative social structures that are disadvantaging LGBTQ persons. So the pathologization of identity. So all of the participants who self-identified as being transgender described the process of receiving supports for transition as being both pathologized and medicalized. The trouble with this, according to the participants, was many layered. Participants described processes such as archaic forms, listing gender stereotypes and asking the person which ones they felt they aligned with, such as mechanics or homemaking, and being asked how they hated themselves as they were or hated their body. And this was definitely not always the case and not how the individual felt. One participant described how they spent many years coming to terms with who they are and what their identity was and being okay with themselves, and how this process, in order to receive care and receive any assistance with transitioning, sought to really undo the progress that they themselves had made by attempting to make them admit they had a mental illness or that there was something wrong with who they were. And so just a few quotes here to highlight. Individuals again saying how problematic the pathologization of transgender people is. It's harmful and problematic and needs to be viewed very differently. And they mentioned how the diagnosis of gender dysphoria as a gatekeeping mechanism towards care is very harmful to individuals. So further descriptions around pathologization of identities. So one individual described how the pathologizing of being transgender overlaps into every area of their lives, that those providing health services as well were so far removed and uninformed regarding the experience of being transgender. So essentially they described how the pathologization and the medicalization of the existence of people who are transgender really overshadows every other aspect of their lives, assuming that this medical condition, this illness, is negatively impacting every other part of their lives. Several participants spoke of this issue and how the focus of every issue in their lives, whether physical health concerns or difficulties with their family or work life, are all assumed to be directly attributable to their being transgender and discrediting every other aspect of their lives. And so this quote here describes that quite succinctly, talking about how it really hurts your credibility. So as soon as you come out, especially as non-binary, but also transgender, everything else in your life and your existence and your experience loses credibility. So your experience in the workforce isn't seen as credible, or your observations about your heterosexual cisgender children also is being less credible. And so they felt that this identity was being overshadowed completely in the eyes of their healthcare providers and everyone that they're interacting with. So the systemic failure to recognize sexual and gender diversity is the next category. So this concern was described by all participants related to failure of the system to even recognize anyone existing outside of the binary or heterosexual categories. And although this didn't necessarily occur in every single healthcare interaction, it was the dominant experience. And so this disregard for anyone outside of the binary or heterosexual categories is often reflected on forms or any medical documentation of any type, and even the types of questions being asked by healthcare providers, or how assumptions are being made and communicated, such as assuming gender and sexuality based on appearances or the norms and values of the healthcare provider themselves. And so individuals described how there's really no adequate system for communicating your gender or how you should be addressed. And one individual further described, stating, deeper than that, there's no adequate understanding of the sort of larger picture of what it means to be trans and receiving healthcare. So, you know, just addressing somebody by names and pronouns is one thing, but also understanding something like how some people don't take hormones, some people do, some people have surgery, and some people don't. Individuals described forms often as quite jarring. The first thing they're asking for gender. Do they want gender? Do they want sex? They're not the same thing, and feeling confused and left out when filling out forms. Individuals also described how oftentimes, even if a healthcare provider did get it right and address their identity appropriately, oftentimes that information was not shared from one healthcare provider to another, or inadequately shared, and that they would have to redo the process over and over and over again. This kind of brings us to lack of knowledge overall. So this includes both insufficient knowledge on the part of healthcare providers, as well as unwillingness to seek out information. Several participants described scenarios where providers refused to provide service based on the status of the individual seeking care being transgender, citing lack of knowledge as a reason for not wanting to prescribe or treat due to uncertainty of how hormones might affect, regardless of the reason for the visit. Other reasons for refusals included, we've never been trained, or I'm not comfortable. Inadequate care around fertility issues was another issue described by more than one participant. And they had indicated that care regarding fertility and sexual health was grossly inadequate in many regions. Individuals described situations including failures to ask whether pregnancy was being sought, only asking whether or not they were having intercourse, assuming they were in a heterosexual relationship, or disregarding medical exams due to their transgender status. And so this kind of brings us to the inadequate and inappropriate care that can result from this lack of knowledge. So one participant described a particularly troublesome situation. And this individual described themselves as transgender, female to male, and how they kept requesting a pap test because it had been several years and they were concerned. The physician kept putting it off, saying it wasn't important, and reinforcing that they didn't want to make the individual uncomfortable. And so this went on for a significant number of months, and the participant ended up having to book one themselves because the physician wasn't providing that, and it turned out the individual urgently required surgery. So a really unfortunate situation. Another participant described a troublesome situation where they had attended a walk-in clinic for a suspected sexually transmitted infection. And when it turned out they were positive for this infection, rather than treating them immediately, the healthcare provider informed them they'd have to wait for further sensitivity results to come back, and that the suffering that they were experiencing in the meantime would be punishment for their lifestyle choices as a gay man. So there's a range between both discriminating and stigmatizing actions on the part of the healthcare provider, and that discomfort or just general not having the knowledge to provide the care and not seeking out the appropriate information and knowledge to provide care to the individuals seeking out help. This brings us to a further distillation within this category, looking at knowledge gaps further. One individual described something called the transgender broken arm syndrome. It's stating that it's essentially like you go somewhere because of a reason, such as a broken arm, and they find out you're transgender, and that's all they focus on. So somehow, again, that it's related to you being trans. And so this is very similar to what some other participants described with regards to the focus of care suddenly becoming their status of being transgender, as opposed to whatever reason it was that they were seeking care in the first place. Individuals also described, in general, not receiving trans competent care overall, that they didn't feel cared for, didn't feel respected, and ultimately never had their actual medical concerns that they were seeking care for being dealt with by medical professionals. And again, a lot of descriptions around questions around inappropriate curiosity again, or attaching labels and misconceptions to their health status, such as assuming an individual is depressed because they are transgender, or inappropriately or incorrectly attributing other illnesses to the use of hormones. And it brings us back to that lack of knowledge regarding what being trans means, assuming that everyone's the same and that all their needs are going to be the same. Or asking questions based on the personal agenda of the healthcare provider, and again, that curiosity versus the need to know. So limited access is our next category. And so avoidance of care and services. So every participant described having avoided healthcare settings or delaying access to healthcare settings based on either their past negative experiences or even hearing from others within the community that the services were not considered to be queer friendly. So the impact, the human impact or the toll with regards to this is safety, because of course avoiding or delaying care and services can result in incredible harm and increase risks of poor health outcomes or even death in some extreme cases. So individuals talked about their experiences, as you can see from the quotes on the screen here, saying, I just haven't gone back. I was like, I really just hadn't, because in those situations, I really feel pretty vulnerable. And the individual in that particular case was pretty overwhelmed talking about the experiences, because saying that they just avoid care unless they are in a state of extreme illness. And even then, questioning whether it's worth it or not to go. And another individual described what it's like to submit themselves to these experiences within the system, anticipating this kind of mistreatment or inappropriate treatment, and that it really wears on your sense of confidence and just overall their sense of well-being. And they described feeling broken by the system itself. And really questioning overall the competency of the care providers that they were going to be potentially seeing. One individual stated, it's like a risk every time. Other individuals described how difficult it is to access services in general. And this isn't necessarily particularly in provinces where there's large geographical distances sometimes to certain services. This can be an issue all over the province. But One individual described how it was particularly difficult because the only counselor in their very small community was faith-based, and they didn't feel that they were safe to be talking to this particular counselor, or that they would be accepted by this particular counselor. So lack of services that are perceived to be either safe and inclusive, or having an adequate level of queer competency was described by all participants. Other issues of inappropriateness included being judged or shamed for their sexual and gender status. However, fortunately, not every participant described entirely negative experiences. Some individuals did describe positive experiences accessing healthcare services. So individuals in these situations indicated that their providers were supportive, knowledgeable, and non-judgmental. These providers were noted to not make assumptions about identities and demonstrated a level of respect for the individual and their needs. As well, individuals described positive experiences were encountering forms, for example, with non-binary options, and that the forms used sensitive language. And these are all aspects that contribute to both the perception of safety and the level of knowledge and sensitivity of the healthcare setting. So these forms were found to be an encouraging sign for individuals. So individuals described in these settings feeling like they could be open and honest with their doctor, either because their physician themselves was from the community or simply had an improved level of understanding. Individuals stated they felt like their choices were respected and that they were knowledgeable and had a lot of supportive information for care. So one of the primary intentions of this research was to try and give voice back to individuals in the community. Often individuals feel unable to voice their concerns. And this is an opportunity for individuals to describe what their wish list would be in healthcare settings, what we can do to improve care, service, and delivery, and make all settings safe and accessible. This is a summary of our key recommendations received. So individuals indicated overall the healthcare system's woefully unprepared to take appropriate care of LGBTQ people. And they stated that overall the dream is for healthcare providers to understand how our sexuality, our gender, our race, our class, our economic level are all part of our health, you know, and how they intersect. And so one participant described having healthcare providers who could understand the importance of considering all these aspects of a person's identity when considering their healthcare needs, and that it was a critical aspect of truly understanding the impact all these factors have within everybody's lives. So recommendations. So providing safe healthcare settings, no assumptions, no judgments, building queer-friendly healthcare in communities, increasing access, information, and support. And the third subcategory, suggesting a radical overhaul, the deep pathologizing gender identities and diversity. So providing safe care settings, no assumptions, no judgments. The one individual stated it quite simply and succinctly: we're all people. So training and education was suggested by all participants for all health service providers. So at all levels, nurses, doctors, mental health service providers, and basically anybody that comes in contact with patient populations, including clerical, intake, etc. So ongoing education should involve basic communication training that's sensitive and inclusive, education on diverse identities, and most critical in all of this was described a concept that is not new to anyone in the healthcare field, and that is around being person-centered in care delivery and seeking to understand the experiences, the lived experiences of individuals and their needs, and working with them together as part of a team. So person-centered care truly involves making no assumptions about any individual, being aware of personal biases and stereotypes, and understanding how to provide care then that is unbiased, caring, and respectful of the individual as a unique person. So part of this approach involves creating a space that is safe and welcoming to all, regardless of who they are or how they appear. And this creates space for individuals to really feel safe to share their stories, and helps care providers, again, understand who their patient truly is. And participants described this as being of the utmost importance. So the idea in part 2 here of upstream approaches. So this looks at addressing these issues and providing this type of education to future healthcare providers. So those who are undergoing education and training to become nurses, physicians, social workers, counselors, etc. And looking at sending them into practice with this background information. So currently, a lot of programs possess either no education and training in this area, or very minimal amounts of education. For example, physicians receiving only a 1 to 2 hour session that incorporates elements of diversity and person-centered care. So we're suggesting that this be incorporated into multiple areas of programs and addressing the issues around gender diversity and kind of eliminating those heteronormative assumptions that are within most healthcare education programs. And so here at BU, we've taken some of those steps already within our program, and we've incorporated elements with regards to addressing issues around non-binary individuals in healthcare, so in our health assessment course in year 2, as well as in our gender and lifespan course in year 3, and including elements with different considerations for different identities throughout multiple points in the course, and not just one session or one single class. So for example, in the course being delivered this particular winter term, when we're examining content around breast cancer and prostate cancer, transgender health considerations are addressed within both of those units, for example. So it's at multiple points throughout the program, and this has been happening over the last couple of years that we've been rolling this out. So the next quote I have here. So individuals describe wanting places where trans people can be supported. So saying if you can't infiltrate schools and other communities very much, at least there's another option in a holistic health sense. So it's like one thing to just go to a monthly support group and like your doctor appointment for testosterone or whatever, but like if you have nowhere else that I can be myself, it would be bad on my health, I guess. So like having a regular community center type thing would be amazing. Like the people can go regularly. So describing wanting another place where they feel welcome and safe to attend. So this brings us to building those queer-friendly healthcare and community settings. So firstly was the importance of improved care for trans persons described. Several participants described how hidden the process of accessing trans health services are, and many healthcare professionals themselves are not aware of the process, who to contact, what is covered, what is not, and who provides service within the province, or where to even look on the internet to find reliable links of information. So this ambiguity and uncertainty is even more amplified in rural communities where healthcare access may already be severely limited. So easy to access information is desperately needed, as well as a referral process that is set up to support and not punish, as described by participants, those attempting to access the care. So with not everything being covered and travel to major centers being required for some care, this process is disproportionately disadvantaging to those with limited financial resources. Services outside of major urban centers were also suggested, that there's quite a paucity of services in rural communities, and very few health services for those wishing to transition, as was described. As described on the previous slide as well, community supports that are welcoming and inclusive can be vital to the mental health and social well-beings of persons who may feel otherwise isolated and marginalized within their communities. And so these are also desperately needed. This quote here, we need to openly acknowledge that the quote unquote difference between sex and gender, aka body versus brain, is outdated, not backed by sociological understanding, not backed by medical understanding, that it is erasure, is dangerous, doesn't accurately reflect the lived experiences of a large and visible marginalized portion of our population. And again, this is part of the holistic change. It needs to be acknowledged in every way possible, from forms to medical care to medical education, that these things are not as simple and binary as we treat them to be. So this participant so eloquently described this next point. And so as described earlier regarding the presumed binary that disregards every person falling outside of the rigid categories, they described it as dangerous and how it ignores and marginalizes and even persecutes persons. So it essentially is denying them of their existence and devaluing who they are. And this was one individual's call for systemic change and acknowledging identities because they do exist. So this final point was the call for a radical overhaul of the system. So again, that non-binary and gender fluidity education to help eliminate some of those binary assumptions. Participants called for an expansion on the belief that has persisted regarding the presence of two and only two sexes thought to be naturally aligned between two chromosomes and observable physical characteristics. And so we do know that there are more than a dozen documented genetic or phenotypic variations that do not completely fit the two simplistic categories, and that they comprise as much as 1% to 2% of the population worldwide. So the current practices that assume that gender aligns with birth sex or the cisnormativity often fail to really adequately recognize the implications that gender identities have for comprehensive and appropriate healthcare delivery. And so healthcare settings that are adhering to these binary assumptions can silence or problematize any outside those boundaries or those binaries, creating healthcare structures that maintain those healthcare inequities. So healthcare providers have been called forward in their role to advocate against laws that are based on any erroneous scientific notions or that have clear ramifications for the health of populations. So, for example, nursing as a profession has an ethical responsibility to advocate for changes in healthcare systems and practice to reduce discrimination and foster equity for patients. And this, again, is what participants are so urgently calling for, is that support and advocacy from those that have the voice and the ability to make a change within our system and our care delivery to make it more inclusive. So making major changes again to the curriculum practices of nursing and medical education programs require acknowledgement of the importance of addressing gender diversity in the course of nursing and other medical healthcare providers. So committing to investing time, content development, and seeking out resources to pursue this goal as well. And changing the way individuals who are identifying outside of those binary identities are having to access care, particularly individuals who are seeking support as a transgender individual for some transitioning, and changing what the gatekeeping mechanisms are for that process. So as I mentioned earlier, that depathologizing the gender diversity identities, and so that having a mental health diagnosis is not automatically going to be required is the dream. So that brings us to the end. I just want to leave you with this one final quote. Again, because it summarized everything quite so well. And again, creating those safe, inclusive healthcare environments. So at the very heart, every person would encounter what a client needs. The dream is for every person you encounter and for clients to have their healthcare providers' understanding and their commitment to that good care. And again, for healthcare providers to understand how sexuality, gender, race, class, economic level are all part of our health considerations. So a little bit of a reference list. And any questions? Or I think I went a little bit long there.
Thank you, Nadine. That was a really great presentation. It was very informative. If you have, and for the audience, if you have any questions, please just put them in the Q&A box at the icon at the bottom of your screen, so that way they can get asked. Okay, so we have one question. Our first question is, did your research touch on the experiences of immigrants and refugees?
That's a great question. A couple of individuals, no one described themselves as being a refugee or a recent immigrant. Some individuals did describe themselves with regards to their race and ethnicity, but they did not disclose their status as being an immigrant or a refugee. It would be definitely a point perhaps to seek out for future research, though, definitely.
Thank you. Our second question is, I'm really interested in learning more about integrating diverse psychologies into curriculum of undergraduate health-related programs. Are there resources or frameworks out there that other programs and curriculum planners can use as examples?
That's a really good question. Unfortunately, there are very limited resources at this point in time. Some other work that I did as I was developing components for our own curriculum, and I did a bit of a search for what other regions were doing, and it was found that most programs, with nursing in particular was my focus, had either nothing or just an absolute paucity of content in their program. So finding actual frameworks and guides are very quite difficult. I do have a book that I have used that I could certainly send a link to, that actually guides healthcare providers on integrating content into the program. And its new edition was from 2018. And I found it to be an invaluable resource as I developed my own content. Definitely, but I found resources extremely limited, but I'd be glad to share the source of that book.
Thank you. Our next question is, does Rainbow Resource not make any resources that outline trans health and availability of services?
There is some information, and that they definitely can link you to additional information that physicians, healthcare providers could definitely seek out. CPATH is also available on the internet as well, and it actually breaks it down into medical guidelines for healthcare providers. So they have really comprehensive sources of information there for all healthcare providers, and it's openly accessible. And I imagine that Rainbow Resource Center would be able to link you to that information as well. But CPATH is available to anybody to access.
Okay. Next question. I noticed the participant number was fairly small. Study number, I believe, was 12. Are there other studies with larger participant numbers? Will there be a future larger group studies?
In our look at the literature, that we found very limited numbers of studies examining individuals' experiences, particularly in Canada. We are hoping ourselves to be doing some research in the very near future, also focusing more on youth, and hopefully with larger numbers of participants. Definitely. However, the nature of the qualitative work as well, oftentimes you are going to have smaller numbers of individuals. There's some very large studies in the US, particularly there's some in the San Francisco Bay Area that we referenced in our work that looked at individuals' experiences, and our findings definitely aligned with those findings. And the distressing part of that is the fact that that study was conducted a number of years ago in the US, and that we are still continuing to find these issues occurring here to this day right around us, so that it feels like we haven't really gotten anywhere. But we definitely are continuing to research, and like I said, we're developing a project right now for rollout in this new year.
Okay. Our next question is, do you have a recommendation of posters or quotes for gender diversity?
Posters. So I'm not sure what you're asking for, like it's somewhere to find posters or for display. Is that what you're asking?
Yes, in healthcare office.
Okay. I don't have any just off the top of my head. However, I do highly recommend contacting Rainbow Resource Center to see if they have any images, posters that they can link you to or share with. I don't personally have a database of them, but I definitely would suggest contacting Rainbow Resource or contacting CERC as well for some of those resources. They definitely can direct you in the right direction.
Okay. Another question is, I believe one of the individuals wants maybe an explanation of what CPATH is.
Okay, so let me just pull open my sheet here where I have my link information. So CPATH, okay, so it's the Canadian Professional Association for Transgender Health. And so CPATH, CPATH.ca is the website, and it's available in French and English. And on there, they have just a tremendous number of resources for individuals and professionals as well. So it's a fabulous resource.
Thank you. So we have two questions from one individual. Their first question is, was there any findings that were unique to Manitoba?
I don't know if I would say that unique to Manitoba, but there were some findings that were a little bit unique to rural areas. And now I think it may have been kind of regionally specific, because we didn't find it resonating with more than two individuals, but they talked about being in what they described as religious or faith-based communities. So living in very small communities where a lot of the healthcare services were religiously affiliated, and individuals described feeling a lack of acceptance and safety because of the nature of these settings. So one individual I know in particular had described how they would go into the waiting room and that there was religious music playing and that there was religious posters, and they felt that they weren't safe to even say that they identified as queer, and or that they would even believe them when they said that they identified as queer, or what that meant, or that they wouldn't understand. And so individuals, assuming that based on the religious nature of these communities, that they couldn't disclose because of the general belief set that they came to understand about these particular areas. And so these were described in rural communities, in a couple of different rural communities by a couple of different individuals. So this could be considered unique, potentially to Manitoba, I guess, in the sense that these are unique communities within Manitoba. But I doubt that it's exclusive to Manitoba, that such communities exist, obviously. And again, these were the perceptions of the individuals with regards to the nature of these communities. What else was unique to rural, though, is the fact that there is just a lack of resources in general. So the more remote an individual is located, or the smaller the community, the less services in general of any kind. And so that in some ways could be unique to Manitoba. But I would say anybody that lives northern in any of our provinces is going to say, wait a minute, that's me. Our community is like that. We don't have anything, or we have to travel 2 hours or 3 hours or more, right? We think of our fly-in communities, for example, that exist all across different regions, different provinces, and that is definitely not something new to any of them as far as the lack of resources. So something that I could just describe as Manitoba specific, I would say would be hard to pin down. Didn't really come across as, yep, that's Manitoba in the data.
Thank you. And their second question is, the concept of personhood or person-centered care is definitely a buzzword in healthcare. Are you aware of any studies that look at healthcare access in general? I'm curious if comprehensive or compassionate care would be a common theme, or there is a statistical difference between LGBTQ people and healthcare in general.
So, you know, there's definitely a lot of examination with regards to person-centered care and understanding the lived experiences of individuals in care and healthcare in general. I guess what the differences is with regards to the LGBTQ community, when we're looking at previous data and research, is the fact that these individuals have known health risks related to their experiences of stigma and discrimination within the healthcare system. And I described, you know, some of how, you know, that manifests for individuals and their experiences. But what we know in the literature as well is that what this means to any group, frankly, that experiences stigma and discrimination, that it leads to avoidance and delay of health and health services, which of course leads to poorer health outcomes. And so that is quite well documented within the literature, and how those health differences are directly attributed. So health differences in the LGBTQ population are directly attributed to their experiences of stigma and discrimination. But of course, stigma and discrimination is not unique to the LGBTQ population. So there's lots of other groups that experience that and will experience health inequities as a result. I'm not sure if I've totally answered your question there. It's kind of a long question. Did I answer it or partially answer it?
Yes, you did.
Okay. Good.
Alrighty. So we'll just wait a couple more minutes. If you have any questions for Nadine, I'm sure she'd be happy to answer them. Okay, I believe these are it for the questions. I would like to thank you once again, Nadine, for your great presentation. I would also like to thank the audience for attending this webinar and for their participation. Do you have any last minute comments to add?
Oh, I just want to thank everybody for joining me, and thank you for the great questions. Just glad to have the opportunity to share
Alrighty.
our ongoing work.
Okay. And that's all for today. I hope everybody has a great rest of the day.
Thank you.
Thank you. Bye.